Today's episode will focus on heart health and how different factors and treatments can lower or worsen your risk of cardiovascular disease. We'll discuss how heart disease is the leading cause of death in American women with the president of the American College of Cardiology. We'll also investigate how ADHD affects your heart and explore whether switching to salt substitutes may help prevent heart failure later in life.
ADHD may be a significant risk factor for 20 types of heart disease, a new study finds. The study included more than 5 million Swedish adults who were followed for more than a decade. About 37,000 of them had attention deficit hyperactivity disorder. Researchers found participants with ADHD were more than twice as likely to develop at least one cardiovascular disease. Their risk was especially high for cardiac arrest, hemorrhagic stroke, and peripheral vascular diseases. The association was also found to be stronger in men than women, and treatment with stimulants and other psychiatric drugs did not significantly impact the results. According to one study author, clinicians need to carefully consider psychiatric comorbidity and lifestyle factors to help reduce the CVD risk in individuals with ADHD. But he adds, more research is needed to determine what biological mechanisms play a role in the association.
Hello, I'm Mabel Jong, and you're watching Health Day Now. Each March, we pay tribute to inspirational women who broke barriers and paved the way for their female successors. Women like cardiologist Dr. Nanette Cass-Wenger, who in 1954 was one of only 10 women in a graduating class of 120 at Harvard Medical School. Dr. Wenger helped change the perception that heart disease was primarily a man's disease. Her work ultimately shaped the diagnosis and treatment of coronary disease in women.
Nobody was really talking much about women's hearts.
Nobody was talking at all about women's hearts because the assumption was that heart disease was a man's problem.
Today, heart disease is the leading cause of death for women in the United States, but according to the CDC, around half of women are still unaware of this fact. Although the field has come a long way since Dr. Wenger became a cardiologist, the specialty remains a male-dominated field, and the public continues to be underinformed about the female-specific risks of coronary disease. To learn more about the role of patient education in prevention and how more female representation in cardiology might help, I'm so pleased to have Dr. Dipti Itchporiya here. She's the president of the American College of Cardiology. So great to see you, Dr. Itchporiya. Welcome.
Thank you so much. It's great to be here.
Well, I'm so glad to be able to talk to you about sort of the number of women who are going after careers in medicine, but women remain underrepresented in cardiology. Only 21% of general cardiology trainees are women. Why is that?
Well, I think women may not even think of cardiology, right? Because I think women have different perceptions of cardiology than men. And they have different goals that could influence their choice. And women may assign a greater importance to the longer term patient relationships and family time, really than to financial concerns. I think that women cardiologists are more likely to report have reported experiencing sex and parenting discrimination, maybe single, not have children, and report less satisfaction in family life. And there's still some clear gaps in compensation, and there's no denying the long hours, right? So lifestyle is certainly an issue. And I think particularly over the last several years, when there's been awareness about, well-being and all of that, I think people grapple with those long hours. And then I think another potential solution is really the lack of female role models, right? And I think that the American College of Cardiology is certainly working hard to address this issue. In terms of the first question you asked, why don't women choose it? I want to, if there's a woman that's thinking about cardiology, I would say that it's an incredible field. We've made a lot of strides. It may traditionally not have been a very female-friendly profession, but that has changed. I think I'm a good example of that. I think we have more role models. We have more flexible work schedules. I think that, robotics and some of the newer technological things can maybe help with some of the lifestyle issues. And I think that to see all of this science translated and targeting women, I think it's a really exciting time in the field of cardiology and for women, because I think that given the fact that 50% of us die of heart disease, to be able to have therapies that can actually help prevent that for women, I think it's exciting.
Do you think that the lack of female cardiologists have long-term implications for the patients they treat? Does a gender lopsided field affect patient care in the end?
Yes, I think the short answer is certainly yes, right? And studies, including one that's being presented at ACC 22, increasingly show that the lack of women in clinical trial leadership, for example, has an impact on the number of women participating in clinical trials. I think the ACC studies show that compared with studies conducted by a male primary investigator, studies with a female primary investigator were associated with a 7% mean higher enrollment of female subjects, with an average of 45% female subjects for female-led studies versus an average of 38% female subjects for male-led studies. So interesting, right? What this boils down to is that generalization of trial results may be inaccurate if the studies are only compromised of men. And so I think improving representation of women in trials yields more real-time, real-life results that reflect a broader patient population. And I think that's the bottom line is preventing and treating heart disease requires a workforce that's as diverse as the patients seeking their care.
Now, the men and women's hearts are different. So what are the different things that can go wrong?
Certainly, women sometimes have more atypical symptoms, right? They don't have the classical chest pain. Now they can, but they may have more neck pain, jaw pain, shortness of breath. So I think it's just important for us to remember that atypical quality. But there are some true sex differences. We know from a pathophysiologic perspective that women tend to have more plaque erosion than rupture. They're more likely to get thrombus. They have more coronary vasospasm. And we have an increased recognition of conditions that predominantly affect women. So coronary microvascular dysfunction, spontaneous coronary artery dissection, Takotsubo's cardiomyopathy, those tend to occur more in women. And so that's helping us to treat with greater precision. But heart disease is the leading cause of death in women, representing 1 in 5 deaths. But women, as I said, experience heart disease sometimes differently.
And what are the treatment differences that are really dramatic in terms of how you used to treat women with heart disease to what they're treated with now?
Well, first of all, I think that treatment differences, while the risk factors like cholesterol, high blood pressure, inactivity, obesity affect both men and women, there are some risk factors that may play a bigger role in the development of heart disease. So for example, women with diabetes are more likely to develop disease than men with diabetes, right? Smoking among women is a greater risk factor for heart disease compared to men. I think recognizing that menopause and pregnancy-related complications, so for example, pregnancy-related hypertension or gestational diabetes, as they call it, is unique to women, and it can increase that risk of heart disease. And the other big piece is emotional stress and depression. We know that that's an important risk factor, particularly for women. And so I think once you identify those things, it can help target that. As far as treatment differences, there are many people that say, well, women in the past may have gotten less percutaneous coronary interventions or bypass. We're moving away from that as awareness amongst clinicians have changed. And as there's this increased recognition that women do just as well with treatments and with therapies, and that we need to be equally aggressive with our female patients.
Why do female patients tend to wait longer before they share their concerns about symptoms they're experiencing?
Well, part of that could be awareness, right? I mean, if you look at it, awareness that heart disease is the leading cause of death amongst women actually declined from 2009 to 2019. That was surprising, right? Because we've done so many educational efforts over the past decade. And but still only less than 50% of women recognize that heart disease is their #1 killer. So I think that there needs to be this redoubling of efforts by organizations interested in women's health to reverse these trends, right? We want to have increased awareness. So I hope that, although there have been a few studies that suggest the opposite, I hope that studies show that community-based programs at churches, grocery stores, hair salons are effective in improving awareness and ultimately outcomes. And I really hope that social media will provide a really important tool to reaching the public about prevention and lifestyle management.
Is there research that you can share related to the meeting that's coming up of the ACC?
So we recently just released several ACC 22 abstracts that were related to women's heart health, including one I mentioned earlier about the link between women's clinical leadership and the number of women participating in those trials. We also have a study that's first of its kind to examine the differences of sex and race and outcomes following the 7 most common procedures for heart problems. And researchers found that women are less likely to undergo these procedures, but even when women do receive, they're less likely to, they are more likely to die than men in the hospital. So that's something for us to look at more. I'm also looking forward to hearing the results from the CHAP trial being presented during the first late-breaking clinical trial session on Saturday. That looks at the impacts of antihypertensive medications for mild chronic hypertension on pregnancy outcomes, because again, pregnancy-related complications have become an important issue when it comes to targeting or identifying women that can go on to developing heart disease. So again, lots of activity, lots of discussions about women's heart health at this meeting.
Yeah, sounds good. I'm all for that. Well, thank you. Thank you so much, Dr. Echavarria, for your time today.
Thank you so much.
My colleague, Dr. Robin Miller of Tryon Integrative Medicine, is here with more information on what women need to know about their heart health. Hey, Robin, great to see you.
Great to see you.
Well, men and women's hearts are different in so many ways, physically, physiologically. So what different things can go wrong?
Up until about 20 years ago, we thought men and women's hearts were the same. We were just mini men with periods. But now we know that's not the case. And so for the last 20 years, more data has been collected and we're learning more, but there's a lot we don't know. So women's hearts are smaller, our walls are thinner, our blood vessels are smaller. We have a more rapid heart rate than men. And when we react to stress, our heart rate goes up. Men's blood vessels constrict because they pump harder and they're more likely to have hypertension.
So with those basics in mind, are there heart problems that only women get?
Well, there's heart problems that mostly only women get. So for instance, broken heart syndrome is like a stun gun to the heart, where there's a trauma and the heart looks like it's having a heart attack, but it's not. Generally, people recover. That's far more likely to happen in women. And once it happens, it can happen again, sometimes provoked by no one knows what. We also tend to get coronary artery spasm, used to be known as Prinzmental's angina. That's more likely to happen in women. And the other thing that's most likely is we don't generally have the usual coronary artery disease. We have microvascular disease, which is in the smaller blood vessels. So it might be missed on a coronary angiogram, the gold standard test.
Women tend to also present different symptoms during a cardiac event, jaw pain, nausea, what else?
Oftentimes it's like indigestion, just sort of a mild chest discomfort, sleeping problems, the sense of impending doom and anxiety, all can be signs of a heart attack or coronary disease. We're just wired differently and different in so many other ways.
Are women more likely to ignore chest pain?
Absolutely. Studies have been done where they looked back on women between the ages of 30 and 55 who'd had a heart attack to see how far back they were having symptoms, some of them a month. And they just sort of ignored it, didn't recognize the symptoms because sometimes they're very vague. In fact, I had a patient who had jaw pain. She went to the dentist twice before she came to see me, and she was in the midst of having a heart attack.
Why do women wait so long?
I think we wait so long. It's a wide variety of reasons. And in that study I mentioned, they didn't want to bother anybody, didn't want to be labeled as a hypochondriac, and again, didn't understand really what was going on, because all the symptoms you hear about in the news are chest pain, radiating down the arm, elephant on your chest. Well, some women do have that, but most don't. I think it's really important for women to pay attention to their bodies. We tend not to do that. We really need to listen to our intuition. If you think something's going on, or most likely it is. So do something about it. Don't take care of everyone first. Take care of yourself. Because if you don't, you can't take care of anyone else.
What can women do to take control of their own heart health?
Well, one of the newer things we found is that your menstrual history has an impact on your heart. So women who've had endometriosis, preeclampsia, polycystic ovarian syndrome, women who have premature menopause are all at much higher risk, and gestational diabetes are much higher risk for coronary disease. So if you're one of those people, you know from the get-go, even when you're young, you need to prevent coronary disease and moderate your risk factors. So stay away from cigarettes. Keep your blood sugar normal. Monitor your monitor your blood pressure. Keep your weight down. Exercise. Manage your stress. Because heart disease is the number one killer of men and women. So we're all at risk. Odds are that's what's gonna kill us. So you might as well prevent it.
And when should women start thinking about this? Is there a certain magic number where, yeah, today I've got to start thinking about it because I'm this age?
Actually, menopause is when things really start to go down. Once we stop having periods, our risk goes up. But I think people should be thinking about it well before then. Something that you indoctrinate into your kids, where you talk about eating healthy, exercising, and managing stress from an early age. Because again, it happens over a long period of time. So the earlier, the better.
Yeah, like everything, it seems. There certainly has been a lot of outreach over the past 20 years or so to get women to see heart disease as their number one killer. Do you think the awareness campaigns are working?
No, I don't. I don't think they're working. I don't know why. Again, we tend to take care of everyone else before we take care of ourselves. So we don't notice things that maybe we should be noticing. And so I think there's a lack of awareness because of that. But also, when the symptoms are that vague, how do you know it's your heart? So the thing is, if you have any suspicion it could be your heart, you should get it checked out. And if you do think you're having a heart attack, you should call 911 and take a baby aspirin or adult aspirin and chew it if you're not allergic to aspirin.
All right, my Health Day colleague, Dr. Robin Miller of Triune Integrative Medicine. Thank you. And our thanks to Dr. Dipti Ichporia, the president of the American College of Cardiology. I'm Mabel Jong, and you've been watching Health Day Now.
Taking a sauna after you exercise may help improve your heart function, a new study finds. The study included people in their 40s and 50s who were not physically active at the start and had at least one risk factor for heart disease, such as high blood pressure, high cholesterol, and obesity. The participants were divided into 3 groups. The first performed 50 minutes of resistance and aerobic training 3 times a week. The second followed the same exercise program but was asked to take a 15-minute sauna after each session. And the final group was instructed to continue their usual sedentary behaviors. After 8 weeks, both exercise groups experienced an increase in maximal oxygen consumption, a key marker for cardiorespiratory fitness. But the researchers say the sauna group also experienced decreases in total cholesterol and systolic blood pressure. The authors say this study opens up opportunities to investigate shorter bouts of regular exercise in conjunction with sauna use and lends support for regular sauna bathing as a possible therapeutic alternative. High blood pressure in pregnancy is on the rise, according to a new study, and researchers say Gen Z and millennial people are 2 times more likely to be diagnosed with the condition than baby boomers. The researchers looked at patterns of high blood pressure in first pregnancies among 38 million people from 4 generations. They found rates of hypertension during pregnancy were highest among more recent generations, regardless of their age. Participants who identified as non-Hispanic American, Indian or Alaskan Native, and non-Hispanic Black were most at risk. The researchers say a decline in heart health among young people and a rise in obesity may be driving this dangerous trend. The lead author says, these findings highlight the need to broaden our perspective on screening and expand our focus on prevention in all age groups before and during pregnancy. People who carry student loan debt into their 30s and 40s face an increased risk of heart disease, a new study finds. The study included 4,200 Americans whose health was tracked for decades, starting in their early teens. About half of the participants said they were consistently in debt due to student or other loans. They were found to have significantly more risk factors for heart disease, including high blood pressure, diabetes, smoking, and excess weight. They also had higher blood levels of C-reactive protein, a marker of chronic inflammation. While the study did not determine why lingering student debt led to worse health, a professor from Northwestern University, who was not involved in the research, says, "Stress has direct physiological effects on the body, and it also affects your behavior, how you eat, whether you smoke." He says people who spend a long time paying off debt have less money for healthy food, a gym membership, or stress-relieving vacations. Student borrowers in the U.S. currently owe $1.75 trillion in federal and private loan debt. Using a salt substitute instead of the real thing may lower your risk of heart attack, stroke, and death from all causes, a new study finds. Salt substitutes replace much of the sodium chloride with potassium chloride, which has been shown to have health benefits. Researchers reviewed 21 international investigations on the health effects of salt substitutes on nearly 30,000 people. Their analysis found that participants who used dietary salt substitutes experienced significant reductions in both their upper and lower blood pressure numbers. Use of salt substitutes was linked to an 11% lower risk of death from any cause, a 13% lower risk of death from heart disease, and an 11% lower risk of heart attack or stroke. The authors say these findings support the adoption of salt substitutes in clinical practice and public health policy as a strategy to reduce dietary sodium intake, increase dietary potassium intake, lower blood pressure, and prevent major cardiovascular events.